Hello, Fit Fam. Welcome to another episode of the Fit Doc Michelle Reed podcast. Today's special guest is none other than fertility specialist Dr. Tia Jackson-Bey, who's going to be talking about reproductive health. She is a board certified reproductive endocrinologist, infertility specialist, and an obstetric gynecologist who cares for patients at the RMA's office that is located in Brooklyn. She is so passionate about reproductive justice and increasing access to fertility care for all people. Dr. Jackson-Bey is a talented surgeon and dedicated fertility expert who is focused on fertility preservation, IVF success, and has great outcomes for her patients. I am so excited and looking forward to talking to her in a few minutes. But first, we're going to just jump on to today's hot topic, Damar Hamlin. You might remember a couple of months back where he had a cardiac arrest. He's a football player for the Buffalo Bills, and he is doing quite well now. Recently, he surprised his grandmother with a home makeover. And, as being a mom of two boys and who played basketball, I am just so grateful that he was able to make the comeback from that cardiac arrest, but he still is passionate about making sure he takes care of his family. He surprised his little brother with a visit right after he had his medical emergency. And you know what? And he jumped right in and did this home makeover for his grandmother. And as I guess a big lover of my grandparents, it's an honor and a privilege because what my grandmother used to say before she died at 102 years old, she lived on her own up until like the last 3 months of her life. But my grandmother always said that each generation is supposed to do better than the one before it. And I'd have to say that Damar Hamlin, you are really hitting it, and especially not afraid to show your spiritual aspect of who you are and what makes you tick. So keep up the good work, Damar. So, we're going to jump right in and bring on Dr. Tia Jackson-Bey, who is an infertility specialist. Hey, Dr. Tia, how are you?
I'm doing well. How are you? Thank you for having me.
Oh, no, thank you for being a part of this. So, I have one little thing that we probably didn't tell you about.
Okay.
What is one thing about you that you might not have told anyone or hardly anyone knows about you?
Hmm. I have to think about it.
Wait a second, I stumped you. That's highly unusual.
One thing that not a lot of people know.
So I had one guest who said that she does square dancing. She loves listening to country music. So if you didn't know her, you were like, "What? Are you serious?" So what is one thing? It doesn't have to be anything like grand, but one thing about you that people probably don't know about you.
I don't know. I love swimming and snorkeling. I could
Oh,
spend all day doing that, and that's what I look forward to most when I'm on vacation.
oh, good. So now we got to make sure that we get that invite to the next Fit Doc retreat so that way you can get in the water and just snorkel your little heart out.
Yes.
All right, so just jumping right in, I just need to set, I guess, some ground rules and some basic terms. So, you are a infertility specialist,
Yes.
and you are a big believer of reproductive health and justice for all, as far as
Absolutely.
in that matter. So, let's just jump back for a quick second. What exactly is infertility?
So, infertility, and that's a great question. Infertility is really the absence of a pregnancy after trying for usually 1 year. There are times where we would start an infertility evaluation sooner than a year, but that is actually the definition of infertility with being able to have sexual intercourse over a year's time in a woman who is getting a period and unfortunately has not resulted in a pregnancy.
And now, are you seeing this more than maybe when you first started in your career, that more women, and around what age are we starting to see people that are coming into your office?
So honestly, anyone can be impacted by infertility. They can be very young, of reproductive age, menstruating women, but what we would consider in our society as younger women in their late teens or early 20s, as well as women who are on the opposite end of the reproductive spectrum in their 40s and into 50s. So infertility is an equal opportunity situation for sure, but we definitely see it more as women get older. And so, as all of us are having families later in life, the average age of first parenthood in the United States last year was age 30. And
Hmm.
so that's the first time that it's moved from the 20s to the 30s for your first child, which just shows and reflects a national and really global trend for having children later in life. But with that comes a higher chance and risk of infertility. So, as more people may just be starting their families in their 30s and 40s, they may run into more issues than maybe a generation or two before them.
And now, how do you break it up as far as the percentage? Because when you say infertility and you're an infertility specialist, everyone always feels that, oh my gosh, it has to be the woman. There's nothing wrong. Or a man might say, well, I've had children before, so it must be you. And I know stress also will affect how you feel and how your body responds to certain things. So,
Mhm.
what is the percentage? Because it's not always the woman.
It's not, absolutely. And it really breaks down to almost 50-50.
Mm.
So if you think about it, probably 40% of the time it's only the woman, but up to 40% of the time it can be male as well. And then the last about 20% of the time, there may be some contribution from man and woman with trying to achieve pregnancy. As society changes and as, we're all kind of expanding the definition of a family, we're also seeing other ways that you run into challenges, particularly women who are parenting alone and men who are parenting alone.
Mhm.
And how do they fit into the definition for infertility? Not necessarily that they're infertile, but they do need assistance in the help of, gametes, either other eggs or
Mhm.
sperm or a uterus from someone else in order to achieve their pregnancy. Couples that are same sex or who are involving trans partners may also need assistance with building their families. And so that kind of increases the population of who we're seeing.
Now, those are all key things. Um, and I know like when I was getting pregnant, like high risk at the time, initially was considered 40, but then all of a sudden it became 35. So if someone is coming to you and they have been labeled as not able to have a child, they're infertile, what is the process that they go through? And then what is, because there's always healthcare disparity in everything. I mean, I've had my own private practice for like over 21 years. So I see the difference in the zip codes.
Yeah.
So, how do you see that? How does it show up in your practice? And I know I just did a double question.
Absolutely. So I will talk a little bit about what does it look like when you are initiating care with the
Mhm.
infertility specialist. Honestly, anyone who has been trying for a year or more without a pregnancy, or if you've been trying for 6 months, but you have certain medical conditions, either uterine fibroids or ever been told that you had polycystic ovarian syndrome or endometriosis, if you've had an ectopic pregnancy in the past or surgery on your uterus or fallopian tubes, if you've ever had a cancer diagnosis and were treated for cancer in the past, or if you have any other medical condition that could impact your fertility, you should really come sooner. You don't have to wait 1 year. You don't even have to wait 6 months. You come right away. For women who are trying, who are over the age of 35, we want to see them in 6 months of trying and not a year or more. The
Mhm.
reason being is we know that it may be more difficult to achieve a pregnancy at age 35 or older. And so you get to cut down on that time and you get to initiate treatment sooner so that we can decrease the amount of time it takes for you to achieve a pregnancy.
Now, before you say anything further, you just threw out a lot of terms. I'm
Mhm.
a doctor, I understand them, but you mentioned uterine fibroids, you mentioned polyps, you mentioned endometriosis and PCOS. So that was like a lot of things you threw out.
Mhm.
So can you just briefly just tell us what each of those are? Because sometimes, you realize even it happens for ourselves, like the doctor's talking to us, we might not be paying attention as the patient, and you say something and they're like, oh, really? And you act like you know what they're saying, but sometimes you don't.
Yeah. I
So,
mentioned those terms because sometimes they may have been mentioned to you, but you may not realize that it has a reproductive impact. So I mean, a lot of people who have been told they have fibroids, they have PCOS or polycystic ovarian syndrome, they have endometriosis, they had a cancer history when they were younger. Now they're better, but no one did the follow up to say, hey, this could impact your future fertility. So I'll start with maybe one of the most common, which is uterine fibroids. Fibroids are smooth muscle tumors, which means that they're a collection of cells that grow from the muscle of the uterus and create little knots in the uterus. Fortunately, fibroids are not cancerous, but they grow and proliferate on their own without any kind of check from your body. And so that is why they are labeled as tumors. They're very common in women of African descent all around the world, be it in the United States, the Caribbean, Africa, Europe. We see it a lot in women of African descent. And so it's a very common problem. Not all fibroids have the same level of impact on your fertility. It depends a lot on the size of the fibroids and the location of the fibroids, and sometimes the number of fibroids that are present. And so you may hear that a lot, or you may hear women in your family say uterine fibroids, or you may hear, friend groups, people talking about it now over brunch. But if someone has ever told you that, or mentioned that amongst the women in your family, then I would definitely want it to be investigated.
okay.
For something like endometriosis, it's actually an inflammatory condition where the lining of the uterus, those cells, the endometrium, are present in places where they normally should not be. So those cells may be present in the fallopian tubes, in the ovaries, and even outside of the reproductive tract on your bladder or bowels. This condition is still very under appreciated in Black women.
Hmm.
One of the hallmarks of having something like endometriosis is pelvic pain. So
Hmm.
a lot of women will experience very painful periods. Young girls may have to stay home from school, miss days of work,
Hmm.
or rearrange their social lives because of their period pain.
Hmm.
As the condition advances and you get older, you may start to have pain even when you're not on your period, and that may indicate a more advanced state of disease, or even adhesion, scar tissue between different organs in your body that can affect your GI tract and make painful bowel movements. It can also make intercourse more uncomfortable. So endometriosis, if you fit any of those factors,
Hmm.
it's worth asking your doctor, could you have endometriosis? Unfortunately, in medical training, we were not taught that Black women are affected with endometriosis, and therefore it is often overlooked. Sometimes there are both fibroids and endometriosis, two conditions that can cause pain. So if there are fibroids, no one does a follow up to think there could be endometriosis as well. So this is something that I have seen a ton in my practice. A lot of people are very surprised when they're diagnosed with it, but it has huge impact on your reproductive health. And so I want to make sure that if anyone's ever said that to you, that you are aware of it and you follow up. Of the last condition, I'll say polycystic ovary syndrome is a condition that was first kind of described in the 1930s regarding women who were not getting regular periods every month, and may also had some issues with acne on their skin, hair
Hmm.
growth on their upper lip, chin, lower abdomen. And then when they looked in their ovaries, they were actually enlarged and contained multiple follicles.
Hmm.
At the time, these follicles, little places where eggs were growing, were called cysts. And when you look on ultrasound, even today, you'll see multiple small follicles on women's ovaries who have polycystic ovarian syndrome.
Hmm.
So this syndrome most commonly is associated with women who do not get a period every month. They may have many eggs in their ovaries, but they don't reliably ovulate an egg every month. And without ovulation, you may not get a period that month. As I mentioned, they may also have acne or hair growth on your upper lip, chin, chest that you have to kind of constantly manage.
Mm-hmm.
They may notice when they get blood work that they have higher levels of what we call androgens or male type hormones like testosterone.
Mm-hmm.
And then they may notice that their periods can be a little bit irregular. If anyone has ever told or mentioned that you may have polycystic ovarian syndrome, sometimes they'll say, well, you can't get pregnant. That's actually not true. Women with PCOS get pregnant every day. As long as you have eggs and you're ovulatory, you get pregnant. For women who are having trouble with their periods in PCOS, we have very effective medications that can help you to ovulate. And so again, it's important to understand how to control these conditions when you're not ready for pregnancy. But when you are, if this has been part of your history, it's important to engage a doctor who can help.
Okay. So you know what? Before you go to the next question that I had asked, um, what if you go to the doctor and you're seeing your regular GYN? You're saying, you want to get pregnant. They're saying, oh no, hold on, hold on, hold on. Can you actually go on your own to see a reproductive doctor such as yourself? And then, what do all insurances pay for this?
So those are great questions to ask, especially because many people in managed care plans may need to have a referral when they go to see a subspecialist. But more and more, the insurance says you do not need a referral. You can actually, book an appointment with a specialist or a subspecialist and walk in on your own. I think that's really important for people to know. Unfortunately, waiting on referrals traditionally has been a huge barrier to care, particularly for African American and Hispanic women to seeking the kind of services that I provide. So I'm excited that people can kind of book these appointments on their own and don't always have to wait for a referral. It's worthwhile kind of calling and asking your insurance if that's the case. Unfortunately, infertility is not universally covered by health insurance.
Mm.
Even though infertility is a medical diagnosis, it's a medical problem, it's not a social problem, it's not a problem of only rich people or only people who can afford to pay cash for care. But unfortunately, it has been left off of many health plans. So right now, there are about 19 states in the country that have mandates that the insurance plans in their state cover some aspect of infertility care, but they vastly differ between states in terms of what is covered, how much of it is covered, and what kind of stipulations for coverage exist. Luckily, in New York State, we have one of the best mandates in the country. But even with that, there are still kind of gaps and loopholes. People who live in New York State but work for the federal government may not have coverage. This means postal workers, people who work for companies that are small or self-employed, less than 100 employees in the company may not have coverage. Or if your employer is based in a state outside of New York. So there's still so many people who don't have access. But luckily, when New York became an insurance mandated state in 2020, tons of people gained access, and it's a big benefit to New Yorkers.
Okay. So, I mean, because I see it in patients who some take out loans because their insurance doesn't cover it. And some people do it multiple times, like two, three times. Sometimes they're successful, sometimes they're not. And then I also see on the other side where people who've gone through IVF treatments, all of a sudden, they end up getting pregnant.
Mhm.
So anything can happen, but I guess the important thing is to be able to know that you are out there, that people can come to someone like you for the help that they need. So going,
Absolutely.
yes.
I
So
think
go,
it's important to know, and it's important to know that this exists as a field. So often, particularly Black women wait longer than their white counterparts. which means that they've been experiencing infertility longer by the time they are able to seek a specialist. Remember, I said we want you to be waiting for 1 year and really no longer than that before you seek an evaluation. But sometimes I see people who've been waiting 5 years or even 10 years without a baby and didn't really know where to go or what next step to do.
So now, do you feel it's because maybe their doctor didn't want to tell them about it, or do you think that, I mean, because a lot of times you know what you know and you don't know what you don't know. So why do you think is a reason that sometimes, like, because now we're going into what I just asked you earlier, is does race play a role in infertility?
Yeah.
So why is that?
So it's there are multiple factors that can be barriers to care for a lot of people. Referral sources is a huge problem, and historically we have seen that African American patients, low income patients, Hispanic patients are referred less even when they're presenting with the same symptoms. Whether or not there's internal bias in the medical system, which has to do with who deserves to have care, with who would actually fulfill the referral request and show up at the doctor, or who can afford care. Remembering that some infertility treatments, if you pay out of pocket, can be quite costly. And so if there's a judgment based on whether or not you can afford it, maybe they don't even send you for a referral, which is not the right thing to do. Every patient deserves to have the counseling, have diagnostic testing, regardless of the cost. They deserve to have, these things explained to them, and they can figure out costs. If you're not covered by insurance, sometimes that can influence maybe the insurance plan you pick in the next year. Or patients can pay out of pocket. As you mentioned, people will open credit cards, they will finance treatment, they find a way. And so to limit people based on judgments about what they can and cannot afford is not right. As I mentioned, other things are big factors in terms of insurance coverage. I've heard people say they lost coverage and they had to discontinue care, or they were waiting, or they even switched jobs to be able to have a better coverage plan, or they lost the job and therefore they lost the coverage that they had. And so those can also be barriers. Lastly, there can be geographic barriers. Luckily, we're in a place like New York City where you can get pretty much anywhere on the bus and the train, and there are lots of practices located here. But some other places, if you're outside of a big city or a metro area, there may not be very many infertility specialists that are close to you. And so that can significantly limit your care as well.
So now you talked about reproductive health and justice. Do you think, Dr. Tia, that it makes a difference if you had a Black doctor?
I have a lot of patients who come to me because they really want to see someone who looks like them, who understands the language that they speak, who can relate to. I think that whatever makes the patient feel comfortable is the most important thing in care, because there's such an intimate relationship between what we do. It sometimes can take a while. There has to be a lot of trust. There has to be a lot of understanding. We talk about very sensitive matters, for both parties or for individuals. And so to be able to have that level of trust, I think, is the most important thing.
And now, is there anything that someone can do to, I won't say to prevent from being infertile, but to make sure that you stay as healthy as possible? So if you do have infertility, it'll make things a little easier to do or to
Absolutely.
possibly have.
Anything that is good and healthy for your overall health is going to be good for your reproductive system. So maintaining a healthy weight for your height is always going to be a good idea. A lot of people don't really feel that that's a kind way to put it when we ask them to manage their weight, or in some cases to lose weight or gain weight. But that is, a very important factor in your overall reproductive health. It helps with hormonal balance. It may help you in how you respond to certain treatments, and overall help you with early pregnancy health. Smoking is probably one of those things that I'd say if everybody could lay down their cigarettes, cigars, pipes, hookah, shisha, this would be a much happier, healthy place.
But wait a second. But wait a second. So, what if somebody smokes marijuana? Because I have some patients who feel that you smoke marijuana that improves your fertility. Because guess what? It comes from the earth, so it's natural.
No, it does not improve your fertility. And in some cases, marijuana has been shown to have detrimental impact on sperm, both on sperm motility and sometimes morphology, sperm count. And so, again, I know that especially with legalization or decriminalization in the state of New York, a lot more people are ingesting cannabis in multiple different ways. I again would, warn them that we don't know all the ways that
Mhm.
cannabinoids and cannabis are going to impact reproductive health. We just haven't seen it for long
Mhm.
enough to know. But certainly for most ingested substances, especially if it's something that is recreational or optional for you, then my suggestion would be to stop.
Okay, we're gonna probably have to put that whole like last minute on like loop, like play it over because most people, especially guys, they don't feel that there's any type of harmful effect.
Mhm.
It doesn't mess with me. My sperm are good, my kids came out good, but we don't know the long term effects
Right.
as to what can happen to your children because more times than not, there are no studies
Yeah.
on that.
And
And
there's the issue of secondhand consumption too. Luckily for men, if there's an issue with sperm that's due to a behavioral factor, if you remove the offending agent, within 2 to 3 months, you have new sperm produced, and you can kind of see a rebound from that. So it can be a temporary effect for some people, which is good. Women don't have that option. We are born with all the eggs that we're ever going to have. We do not regenerate new eggs. So, insults from outside environment, from smoking, from drug use, from, extreme weight situations, even from, taking different medications, like if you've ever required chemotherapy, we don't have the way to regenerate new eggs or repair damage to the eggs that we have. And so that's something to remember and be mindful of as well.
now, as far as, I mean, that was a mouthful right there. But as far as reproductive health, was there anything that maybe we did not cover? Because I don't know if people really understand that justice is not necessarily voting, that reproductive justice in your field, as far as infertility, shows up as what?
It shows up as people deserve the right to have the family they want to have. It should not be, it should not matter what your race is, what your legal status is, what your insurance coverage is, who your employer is, where in the city you live, what your marital situation or sexual orientation is, your prior medical history. People deserve to have the families that they want. And so, we exist as a field to help you navigate that. That doesn't mean that every single person will be physically able to have a child, but helping you to understand what the options are, what's available to you, and how you can navigate the path to your family is important.
Yes. So, Dr. Tia, before we wrap it up, I know many people are going to want to come to see you or to have consults with you. Do you do any telemedicine or is everything in the office?
Yeah, we definitely do telemedicine consults. That was one of the benefits of the pandemic in medicine, and so we are very open to doing telemedicine as consultation. But like many other physicians, we have to be able to lay hands on, and that is a component of the care as well. So there can be a telemedicine component as well as in office, and that allows us to do an evaluation. When you come into an office like mine, we talk about your history. I want to know if you have been pregnant before, what happened in those pregnancies, your gynecologic history. We talk a lot about your period because I need to know all the ins and outs. There are lots of clues there that can be helpful for which way to go or what kind of diagnosis there may be lurking. I need to know about your medical history. Do you have chronic medical conditions that could be impacting your health? like high blood pressure or diabetes that's poorly controlled, autoimmune illnesses. So we talk a lot about that. Prior surgery history is important too, and even sexually transmitted infection history. So we talk about all of these things, age-related screenings like pap smears, mammograms, and even colon cancer screening now. And so we do a lot of talking on the first visit. Another important component of what we do is an ultrasound. You know, for anyone who's born with ovaries and a uterus, I'd like to be able to figure out what's going on.
Mhm.
You know, in order to achieve a pregnancy, you need at minimum four things. You need a uterus, you need fallopian tubes, you need ovaries that contain eggs, and you need sperm. And so the ultrasound allows us to evaluate the uterus and ovaries and make sure that there's nothing there that needs to be addressed. Sometimes we use labs or blood work to help us
Mhm.
evaluate the function of the ovaries, as well as making sure that other hormone systems are doing well and there's nothing, again, that may need to be addressed prior to trying to get pregnant. We'll ask you if you have a male partner or if you are male to do a semen analysis. It's a very simple test, very cost effective, and it gives us a snapshot into male reproductive health. We want to know about the volume of semen, how many sperm there are, how well they swim, and how well they look, like the shape
Mm.
of the sperm. So, super important, and is usually an initial first step. A lot of people leave their male partners home when they come for these
Mm.
visits, but I like to see couples who are trying together because I think it's important for them both to hear what we have to say and
Mhm.
both to feel invested in the evaluation. Lastly, we may do a test of your fallopian tubes called a hysterosalpingogram, and this lets us to know if the fallopian tubes are open. Fallopian tubes are like a tunnel between your uterus and ovaries, and that's actually where sperm and egg meet after the egg is ovulated, and where the early embryo grows and develops before it travels to the uterus. So if one end of the tunnel is blocked, then
Mm.
something can't get through. Also, if there's major road work or construction in the tunnel, then that might result in a ectopic pregnancy where
Mhm.
the embryo can't reach the uterus because it only knows what day it is. It doesn't know exactly where it is, and it knows when it's supposed to start to implant. So those are pretty much important components of the evaluation. We do a lot of talking. We'll do some imaging with the ultrasound, some blood work, semen analysis, and fallopian tube testing.
So, Dr. Tia, you are an excellent teacher. Because you break it down so everybody can understand. Um, it's important for the female to be there, it's important for the male to be there. If you don't have a partner, you will also talk them through, the patient through how to access and get sperm, and also how to view who is a good, appropriate candidate for that mom or that mom to be.
Right.
um, Now, my last question is, how do people reach my Dr. Tia, who is a excellent physician and a wonderful teacher?
Absolutely. So you can reach me many different ways. I know a lot of people like to reach out on social media. You can find me on Instagram at Dr. Tia Jackson-Bey. You can also call for a consultation. And so you can book either on the RMA of New York website or by calling our main office at 212-756-5777.
And now, do people only have to live in Brooklyn, or can like people from Long Island or
I have
Manhattan?
patients from all over the world who come really, literally here to get care. So
See?
all over the tri-state, even up to Connecticut, Jersey, DC, California, Florida, Atlanta, whichever. The thing about it is you have to be willing to travel here for care.
Mhm.
We have patients who fly in from London, from Nigeria for
Oh,
care.
wow.
So there's no limit there. I'm here, but you can come in from anywhere.
Wow. So thank you so much, Dr. Tia. Thank you for doing what you do. Your role, especially as a African American female physician, is very powerful. And I hope just by having this conversation that you will encourage other young males and females to go into your field, because I know, especially in primary care, as far as physicians, we're a dying breed. But I need to make sure that people know that there are other aspects of medicine that they can actually go into. So thank you so much, Dr. Tia, for being on the Fit Doc Michelle Reed podcast.
Wonderful. Well, thank you for having me.
Thank you. So now we're going to just jump right into my favorite segment, and that's the Dr. Michelle in real life. That's Dr. Michelle IRL. So, you know how every Saturday for the summer, I think we might have missed 2 Saturdays, that we've been having the Fit Doc boot camp at Hempstead Lake State Park. And we've been doing it along with Coach Ty from Team Extreme. But guess what? Everybody has to take a vacation. So a couple of times I've had to lead the class. And, people think like, oh, yeah, you're a personal trainer. You don't know what to do. But you know what? I bought my dumbbells and my kettlebells. Everyone bought their mats and a positive attitude. And I worked them out. And it was a rainy day. We found coverage underneath the gazebo and we put in the work. And I know it was intense enough that the next day, 2 people reached out to me on social media. And one of them, he's like, oh my gosh. He's like, Dr. Reed, he's like, I'm a little sore. It was good. I'll be back. And then one of the females was like, oh man, it didn't look like we were doing a lot, but we must have been doing a lot because I've been using some muscles that I've never done. So I enjoy the fact that we are out there early Saturdays, getting in the exercise, moving our bodies. Because I always say that when you look good, you feel good, and you are full of so much energy to do so many positive things. So thank you everyone who's been tuning in or showing up at Hempstead Lake State Park to do the work with us. We've been trying to show like how to do it as a modified level, because you see us going at a certain speed doesn't mean that that's the level that you need to go at. So that's why we have the modified. So feel free to join us 7 a.m. Hempstead Lake State Park. Once the weather gets a little chillier, and maybe if we have inclement weather, we're probably going to take it inside. So still looking for a place, but stay tuned on Facebook and Instagram to where we're going to be when the weather is bad. So I encourage you, if you are not in New York, you can still join us to exercise by just tuning into Facebook. I thank Dr. Tia for being on the show. And more so, I thank you for being a part of the Fit Doc journey. So please like, share, comment on this Fit Doc Michelle Reed podcast, because this is everything that you are interested in. So I get my ideas from you, because you say, you know what, can we talk about infertility? Guess what? I'm going to get a great infertility specialist for you. So let us know what you're interested in. Like, share, comment, and most of all, tune in next time, Fit Family.